Good morning, everybody. My name is Charles Surtwell. I'm the President and CEO of Northern Policy Institute. I want to welcome you here this morning on behalf of NPI and our partner, North Superior Workforce Planning Board. I wanted to highlight that this event will be recorded and made available on our website. We at Northern, we also want to thank our sponsor, Medavie, for helping us to continue the important discussion of the risks and opportunities related to digital delivery of healthcare. Before we get into the proceedings this morning, I do want to take a moment to do an acknowledgement around the land in which we operate as an institute. NPI and NSWPB would like to acknowledge the first peoples on whose traditional territories we live and work. We are grateful for the opportunity to have our offices located on these lands and thank all the generations of people who have taken care of these lands. We recognize and appreciate the historic connection that Indigenous peoples have to these territories. We support their efforts to sustain and grow their nations. We also recognize the contributions that they have made in shaping and strengthening local communities, the province of Ontario and Canada. We are pleased to welcome Dr. Sarah Newbery, who will be moderating this event. I've got a formal introduction for Dr. Newbery in a second, but I would be remiss if I didn't point out that in NPI circles, Dr. Newbery is known affectionately as Mateo's mom. That's an inside joke. Mateo was one of our experienced North interns, worked with us very successfully, and he's been gracious enough to give us access to his mom ever since. So whenever she says no, we call Mateo, and he uses his influence to encourage her to say yes. On that note, I'll highlight that that Experience North 2022 has kicked off, and we've got 8 positions for summer placements. So any of you moms out there in Northern Ontario looking for a reason to draw your kids home for the summer, NPI has 8 jobs available. In any event, Dr. Newbery is the inaugural Associate Dean of Physician Workforce Strategy at NOSM. In this role, she works with faculty, communities, and other partner organizations to support strategic initiatives to enhance the physician workforce for Northern Ontario. She's a rural generalist family physician, 25 years in the community of Marathon, and she's held leadership roles in primary care, the hospital sector, the OCFP, and the Northwest LHIN. She brings her knowledge of Northern Ontario and healthcare system to her role, her multiple roles. She's a true leader, and I'm excited to turn over the reins of today's event to Dr. Newbery. Sarah, do you want to take over?
Thanks so much for that lovely introduction, Charles. And it's really good to know what goes on behind the scenes to get me to do this kind of work. So thank you for that. It's truly a privilege to be here with you today and to be able to join you from my community in Marathon and the traditional territory of Big Tigong First Nation. As Charles mentioned, I've been a rural family doctor for the past 25 years. And in fact, in this community, we were early adopters of digital health, led by a local physician champion, Dr. Brian McLeod, in 1999. We embraced the Ontario Telemedicine Network and the opportunity to do telemedicine for our patients, recognizing the ways in which that saved them significant travel time and brought specialists closer to us. We also had the opportunity to pilot the OTN teledermatology platform when it launched. We are active users of eConsult, are looking forward to eReferral, and really working hard to embrace the ways in which digital health technology can help us to better serve our patients. I think we have really seen through the pandemic an explosion of virtual care delivery tools, and I think we're at a really important time to have a conversation about the ways in which we can use virtual health and digital tools to support care delivery and the right care at the right time. And virtual tools can certainly make care more accessible, cost-effective, timely, and we need to ensure that it also delivers high quality care for our patients. In Northern Ontario, we are also aware of an emerging tension about the ways in which virtual care can bring care closer to home for patients and for people who have historically struggled with access to care. But at the same time, we need to be mindful of the ongoing need for boots on the ground clinicians who can deliver the face-to-face care that we know continues to be needed in many of our communities. So I think it's really terrific that Northern Policy Institute has stepped into this space with their thought leadership to help ensure that we have the kind of discussion that we need to have about ensuring that we're adopting best practices and good practices in telehealth in a broader conversation about eHealth services delivery. And I look forward to seeing the ways in which the Northern Policy Institute takes our shared learning from today to inform policy and to inform the ongoing conversations that will unfold in the Digital Society workshop series that they're undertaking. So again, it's really a privilege to be part of the conversation today. I want to tell you a little bit about the format today. We have 3 speakers, and they're each going to speak from their perspective around digital health for about 20 minutes, and then we'll have a few minutes for questions. You can post your questions in the Q&A box. You'll find the Q&A box in the bottom bar of your Zoom window. Your questions will be forwarded to me. I'll happily ask them on your behalf. We'll have each of our speakers in series, and then the last 20 minutes will be a panel with all 3 speakers, and you can bring questions forward that any one of our speakers can respond to, and we'll aim to close by 11 o'clock this morning. It is my pleasure then to introduce our first speaker, Anders Tunold-Hanssen, who's the CEO and project manager for the Nordic Interoperability project. He has a background from marketing and communication and has worked at the interface between consulting and entrepreneurship. After the establishment, build-up, and successful exit of 2 startups, Anders entered into a management for hire position within the healthcare IT sector in the Nordics. He's also led a national showcase initiative focusing on the sharing of health data across local and regional silos. And since 2018, he has led the Nordic Interoperability project with the ambition of making cross-border patient and health data mobility the Nordic reality by 2030. I have to say, I'm really excited to hear from you, Anders. We struggle with data interoperability even within our own province, let alone across provinces or across countries. And to know that you are doing this across the Nordic countries of Finland, Sweden, Norway, Denmark, Iceland, and the areas of Greenland as well is really a remarkable accomplishment. And we look forward to learning from you today. So with that, I will turn it over to you.
Thank you very much. Can you just confirm that you can hear and see my picture?
Yes, I can.
Yeah, and thank you for that introduction. The project that I'm leading, called the Nordic Interoperability Project, has, as we were mentioning, the ambition of making cross-border patient and health data mobility into the Nordic reality between these 5 countries. And as you said, interoperability and sharing of data is for very many people. I think for all the people who work in health data space, a local challenge. We haven't really solved the problem of local sharing of health data either. And it's a lot of people working on that on a local or regional or even national level. So a lot of good work is done in that perspective. But we felt in this northern part of Europe that national focus would very soon not be enough. We had to, at the same time, be starting to thinking about how to utilize cross-national border solutions to make sure that we had the best solutions available for the people in the Nordics, but also to be able to utilize the new and modern technology that needed bigger databases than what one of these countries could provide for. And that was kind of the starting point for the initiative. But I look forward to present to you the initiative that I'm leading, and please feel free to ask me questions afterwards or in the panel afterwards. So let's see if I can find my presentation. Please, if anyone could confirm that you can see my slides.
Yes, it's great.
Great. And the storyline that I will tell you about, I have to start with my background, which is then marketing and communication. So my background is not medical, it's not IT, it's more on marketing, communication, and entrepreneurship. And I think that that is the background that has been very helpful in starting what is a startup initiative on a project basis, but focusing then on the healthcare side and the IT side, but also then to see the opportunity that lies within this space. And the whole project is focusing very much on a Nike approach. Let's do stuff instead of just talking about it, and I'll come back to that. But for that reason, this tagline of a little less conversation and a little more action, please, is very well descriptive of the initiative. I also want to introduce this little girl that is drawn on the side of the slide. That is Alva. Alva is a very Nordic name for these 5 countries. And she is our representative of the patient some years ahead of us, when then this sharing of data and mobility has become a reality. So we use her for historic purposes and to remind us all what we want to achieve. The whole initiative have started out of a lot of discussions in the Nordic region. And when I talk about the Nordics, it's probably a very European way of thinking of it, because there's probably more regions that talk about themselves as the Nordics. But for this purpose, it is Norway, Sweden, Denmark, Finland, and Iceland. And the Nordic region have, they are independent countries, but they have what is called the Nordic Council of Ministers, which is a cooperation between these 5 countries. So, and we have a long history of working together, of cooperating on different areas. So putting the Nordics on the agenda is quite popular on different international conferences and meeting places. At the HIMSS conference in Spain in 2018, at the Nordic meeting, the Nordic delegation meeting, the topic for this discussion was the sharing and using of health data, the Nordic reality. And this was just one of many meetings where the Nordic cooperation had been discussed, because it has been a very popular topic for discussions. The challenge was only that nothing much happened. And for that reason, after the meeting in Spain, some of these participants put their heads together and said, let's do something instead of just talking. When we collect smart people from the Nordics in a room like that, talking about the sharing of data, interoperability, the use of digital solutions, it's very easy to agree that it would be great to work closer together in a region like the Nordics. It is also very easy to agree that we are definitely not where we want to be at the current stage. And it's also very easy in a room full of smart people to come up with a lot of good ideas of what to do. The problem is just very practical. When those smart people are leaving that room, most of them are going back to a national, regional, or local agenda and responsibility. So very few people had the responsibility of doing something on a Nordic basis. And then nothing much happened until they met again at another conference, starting the discussions all over again. So this was the starting point for see if we could do something instead of just talking. So my first job when I came into this work as a project manager was, of course, to reach out to the healthcare community from different stakeholder perspectives in the 5 countries, so that we would have representatives both from the IT industry, from the pharma industry, from the authority side, from research perspectives, and also to have all 5 countries represented. And this is some of the organizations, Nordic organizations that joined this initiative in the beginning. And now we are quite a big group of supporters to the whole initiative. The initiative that I'm leading is having a goal that is highly ambitious to create interoperability across 5 countries. But the goal of the project is not set by us. It is an ambition that is set by this Nordic Council of Ministers, because they decided around the same time as this project started that by 2030, the Nordics should be the most sustainable and integrated health region in the world. So they even made a film that showcased their future patient called Sophia, traveling across these 5 countries that you can see on the slide, and had her data available either for care purposes or for research and innovation purposes. So we haven't said that this is the ambition. The Nordic countries and authorities have said. So for that reason, the only thing we did was to take them seriously and take them up on their promise and their ambition, and said that we support that, but we want to see something happen. The reason for this being an important ambition for this region is, of course, to build a better and safer everyday life for the Nordic citizens. But also, of course, that we are small countries in the bigger perspective. So to make sure that we had a viable marketplace for the industry to develop from, it would be hugely beneficial if we could create the Nordics as a home market for the Nordic healthcare industry. But also because we want to see the best solutions coming into the Nordics for the Nordic citizens, it would also be beneficial for us to look at this as a one home market, so that international players would look at this region as an international region to enter into. And of course, to build simplified access to health data across these 5 countries for research and innovation purposes. Now, this ambition of the 2030 perspective is of course ambitious, and it's visionary, and it's decided. But at the time when the decision was made, it wasn't really filled with a lot of content. So what happened next was that, led by the Copenhagen Institute for Future Studies, which is a quite famous think tank in the Northern Europe, they led a project called the Nordic Health 2030 project, which led to this report that you can see in the top of my picture, the Nordic Health 2030 report. They spent approximately 6 months with stakeholder meetings representing all of the 5 countries and the different stakeholders, where we sat down and we discussed what should the picture of 2030 be like, and what is the challenges that we face, and why is it so important to reach this ambition. I will come back to that report because that's very leading for the work that we're doing. The second report that you can see on this picture is a report that came out also an organization under the Nordic Council of Ministers called Nordic, focusing more on research and innovation. But they made a report approximately at the same time called the Nordic Commons. That report is addressing the huge amount of quality data that these 5 countries actually have, also from historical times, or a long time going backwards, because they have been in the forefront of collecting data, health data, and to store it in available spaces in different data lakes. But the report is also pointing towards the fact that with modern technology, modern diagnostics, and personalized medicine, these national data lakes would very soon not be big enough for the modern use of data. So that report is also pointing towards the need of being able to share health data across these 5 countries to get databases and data lakes big enough for modern research. And a third report that has been done in this region is also important, because one thing is the technical sharing of data, or the need for connecting these different data lakes, and from a technical point of view that could be possible, but you also have the legal interoperability perspectives to look into. So based on these 2 other reports, we helped them take an initiative on developing the first legal report on interoperability, where we had a legal company look into the different legislations in these 5 countries, not from a perspective of why is it a problem to share the data, but more from a perspective what is possible within the current legislation for sharing of health data across these 5 countries. And in that report, there's also recommendations for all 5 countries, what to change and what to do to make sure that we have a legislation in these 5 countries that opens up for data sharing across these regions. But going back to this Nordic Health 2030 perspective, one of the findings in those discussions and that scenario process was that the Nordic healthcare system is not sustainable. And one of the reasons for that is that currently in these 5 countries, we have quite a high focus on healthcare, or what you could call sick care, care that when you have become a patient, so much that we spend approximately 11% of GDP on traditional healthcare. Money running into the system when you have been defined as a patient. But in these 5 countries, we spend approximately 0.3% of GDP on preventative care, which is nearly nothing. So in this report, it's pointing towards that this equation is not balanced enough. We have to invest more in preventative care, reaching out to all the individuals to get them on board, focusing on preventative care, and also a more a better care process so that they can be more involved in the whole perspective of their own health, so that we could move towards a more balanced equation called the 5-5 aspiration, where we invest more in preventative care to ease the burden on the traditional healthcare. To make this happen, the report pointed on 3 areas where we had to focus. First and foremost, we had to look into another way of thinking and another social contract with the individual, so that the individual could be more involved in their own preventative care, but also in their own care, so that the individual could be looked upon as a resource in the whole picture of the healthcare system. We also had to find new ways of sharing data, not only within the system, but also between the individuals and the system. And we also need to find new business models that also rewarded preventative care. Currently, it's hard to measure what is a good preventative action in such a way that we could build a business model around it, but that is something that we have to look into. And I'll get back to that. In that report, they have also made a very nice picture of a balanced model where you have the individual on the one side, the healthcare system as we know it today on the other side, and the data in the middle. And this model is very balanced, and it looks like the data is floating very nicely between the individual and the system. And this is, of course, the 2030 perspective. If we had looked at this from a 2021 perspective, the individual would be more or less not visible, because we lock in the data and the health data in the system on behalf of the individuals. So moving forward, we have to get the individuals more involved. So from my perspective and the perspective of the Nordic Interoperability project, we took this model as a good inspiration for areas where we could make a difference. So one of the initiatives that we have taken was based on this middle report that we looked at, what was called the Nordic Data Commons, the need for combining the data lakes across 5 countries. We are currently working on a project where we could look into how we could connect and utilize that data for the sharing of AI models, CE-marked AI models across these 5 countries. If we are able to do that, and if we are able to connect those data lakes, that would be huge beneficial for this region, for research and innovation purposes. But it would, according to this model, only be connection of data already collected and locked into the healthcare system. It wouldn't in any way get the individuals more involved in the total picture of the healthcare system. And for that reason, we took another initiative, which we have called the Nordic Digital Health and Medication Platform, where we are looking into quality evaluation and activation of digital health solutions in such a way that the individuals could be guided to use the best solutions, either for preventative care or for a care process. Given that we get this platform in place, we will not only use digital health to help collecting data and be used in the traditional healthcare system, but we could also put digital health solutions in the hands of the individuals in such a way that they could also be a resource when it comes to collecting of data also on preventative care side. So we look upon this as a huge potential for getting individual support, no matter where they're living, whether or not they're living in the big cities where there's a lot of resources to help them, or they live in more scarcely populated areas that we also have in the Nordic countries. And of course, we are looking into how this can be beneficial for the individual in some kind of a health passport. But for this purpose, I'm going to focus on this Nordic Digital Health and Medication platform. So what we did was that we looked into the digital health potential, and we saw that with a huge, enormous number of health and fitness related apps that is currently available on different app stores, and a huge number of downloads every day, that this is a booming industry. But in these 5 countries, in this area of the Nordics, we also saw that there was absolutely no guidance to help separating the good solutions from the bad. Me, myself, as an individual in this area, I was only pushed to Google Play or Apple App Store to find an app that I could think looked fun and start using that. But even though I would collect a lot of data in that app, whenever I got ill and had to go to the doctors, that data would be of absolutely no use because it wasn't quality assured in any way. So for that reason, the work that I would do to collect data on my own situation would absolutely be a wasted resource in the healthcare system. So this is one of the challenges that we look into. How could we challenge that? And to get digital health uptake on board, there's a lot of things that has to happen. But if you look at how to unleash the power, one of them is that we have to make the individuals aware of the digital opportunities that is out there. Currently, smart people find them on Apple App Store or Google Play, but we could do it in a much more structured way for them to be aware, both the individuals and the health professionals, of the huge opportunities that lies within digital health solutions. When they are aware, we have to make it easy accessible, not through Google Play or Apple App Store, but through guided sources where you can feel safe that these solutions are selected because of a reason and they are safe to use. So we have to make it easy accessible for the individuals. Then we have to build trust, that people trust the digital solutions and are willing to use them, not as a compensation for a doctor's meeting or a hospital meeting, but just as an add-on to their own situation. And we have to make sure that these solutions are trustable, not just there and then, but also over time. So we have to put a governance model into play. So this is one of the reasons that we started working on a project that was called the Nordic Digital Health and Medication Platform, and focusing on how to quality assure digital health and make sure that they get trusted solutions. It's very easy to focus on how to evaluate what kind of standards, what should be the requirements for a quality solution. But it's very important to look at it from a broader perspective, because the assessment and accreditation process is just a starting point. When you have quality assured solutions, you have to promote them and disseminate them so that it can get out there to the people who needs them. You have to activate the professionals to make them trust the digital solutions and be feeling trusted to use them, and also to recommend them to others. We have to integrate them into a care pathway in such a way that it could be a resource and not just an add-on that makes problems and more work. And of course, we have to look at the commercial side of this, how we could put digital health on prescription solutions to make sure that we have business models behind. And unlocking this potential of the digital health solution in the Nordics, we looked very quickly at, this is not about a standard, finding a standard to follow, it's about establishing a system. And it's all about having the focus on evaluation of the digital health solutions, while we at the same time have focus on activation, both activation for the health professionals, but also activation for the individuals, to make them trust, make them feel comfortable, make them understand how to use it in such a way that the quality of such solutions is being used by the right people at the right point of their health care process. So what we did was that we sought support, financial support from the Nordic Council of Ministers, and we built a process that we have currently been working on for 2 years on how to make something like this happen. So what we started with was to cooperate with stakeholders across these 5 countries, focusing on how to build accreditation and review services for the digital health solutions. We wanted that to be based on international frameworks and standards. We wanted to include Nordic specific requirements, But we also wanted to look into how could these digital solutions be a source for health data and also then have focus on interoperability. When we then had gone through these solutions, we wanted this to be easy accessible also for international markets. But we also wanted to make it easy accessible for the region and build then what we could call our Nordic warehouse for the approved solutions, so that we don't put them on Google Play or Apple App Store, but we put it in a Nordic warehouse where the authorities could find the approved solution and start using them. And then be focusing on dissemination and activation services through the national authorities, either through over-the-counter way of thinking of digital solutions directly to the individuals wherever they are, or through professional channels and through the health professionals and prescription solutions, so that we could look at this as a system for getting digital health out there instead of just looking at it as a standard to follow. Not going into that, we've been looking at different frameworks and standards from all over the world to find something that could be suitable for the Nordic region. And we have now built a Nordic baseline review with enhanced review components and interoperability components that could be the way through for digital health solutions to be approved into our Nordic warehouse. And we have then built the requirements, a long list of requirements that could be the starting point for the baseline review. We have built a digital platform for the industry, easy to go through the process and have their systems approved. And we have also built this Nordic warehouse where for the authorities it could be easy to find different approved solutions and start using digital health solutions. And of course, for each health solution that have been evaluated, there's also information on each of these apps for anyone to look at to be feeling safe and certain that the solution they use is good. So at the end, must win for getting this into a Nordic-wide and a cross-border solution is that we have to address both the individuals and the health professionals with the digital health solutions. We have to have common evaluation criteria across 5 countries to make sure that it's easy for someone who wants to develop a useful solution to get market access big enough for them to have a business model behind it. We have to have a flexible delivery model for the evaluation process in such a way that each of the individual countries could decide themselves how they would like to evaluate and distribute the solutions, as long as they do it on common evaluation requirements and also with a distribution platform across these 5 countries. And then have this platform for the storage and distribution of the solutions so that a solution approved one place could be of benefit also for other solutions, other individuals in the Nordic. So that was the project that we're working on in the Nordics.
Great, Anders, thank you so much. I'll just wait for my video to pop up, but I really want to say thank you for that presentation. There's so much richness there, I think, for us, and you have hinted, I think, at the fact that our geography is not dissimilar. We too have a widely dispersed population. Much of the northern end of the Nordic countries has that same kind of dispersed population, and I think that there's a lot that we can learn from you. And there are a couple of pearls that I've certainly taken away. The way that you opened around, we can have a lot of conversation, but we actually need to dig in and get moving and take some action. I think that's something that we need to remind ourselves of as well. And I was also really struck by your statement that what you're creating isn't a standard, you're creating a system. But you also talked about using standards to inform the development of that system. And I think that that's a really helpful sort of foundation for what you're building. But in the system, I hear a nimbleness and a responsiveness based on standards, but not limited by those standards. And I think that's really a helpful a helpful thing to have heard. So thank you for sharing that. We do have a question from Holly Parsons, who's asked, what lessons or best practices from the Nordics can be learned and applied or adapted for Northern Ontario? And I might just amend that question to ask if you could pick one or two things that you think are the most important lessons that you've learned that we should carry forward in Northern Ontario. I wonder what you would share.
I think that in the journey that we've been on for the last 2-3 years in the Nordics, I think that what has been the most useful tool for us have been the development of the Nordic Health 2030 report, the first report that I mentioned, because even if it's not a perfect picture of what we would like to be like in 2030, it's a good enough picture for all people to understand that we are moving in the same direction. So have that as a common ground and to be able to use that report and to explain that report to different stakeholders that this is what we would like to achieve in 9 years, 10 years time, I think it has been really useful. Because otherwise we would all be trying to do our best, but we would try to do it in different directions. With that report in hand, with different stakeholders involved in developing that, it has created kind of a picture, a common picture of what we would like to achieve. Then it's so much easier to then build actions based on that kind of future picture of what we would like to do.
Thank you for that. I think that that's, we often talk about having that shared vision that we can all line up behind. And from one northern country to another, I think we often talk about having a North Star. What's the North Star that we can follow and pursue as we move forward to make sure that the actions that we're taking are moving us in a direction of shared purpose. And I think your reminder about the importance of those foundational reports or foundational guiding documents is really helpful. Thank you for that. I have another question. I think we have another minute for another question. And the question is this: have you considered other data, such as cost to police, to address health issues around addictions, mental illness, overdose, etc.? They're often forgotten from a health planning discussion standpoint, but do create significant costs in the system and resources to address those. So wondering about that in the context of the cost burden to the system. You mentioned the GDP and sort of that comprehensive costs of healthcare delivery and costs that may sit outside of a Ministry of Health, but certainly are costs that are borne because of illness. And I wonder if you could speak to the inclusion of that kind of data in your work.
Yeah, we have in the different stakeholder meetings, the discussion meetings we've had, we have looked at how to solve the 2030 problem in different ways. And one of the things that we have looked into is to mix different data sources into a better data lake of information so that we could have better decisions made based on a broader perspective. We haven't done it yet because currently we have more than enough to kind of push the health data and be able to utilize the health data in a good way. But we definitely look into that because I think it's important to look beyond the traditional silos. And when I take the perspective of an individual in the Nordics, one of the things that we see is that an individual in the Nordics can today share sensitive data when it comes to their bank information data, but they can't share their health data. And I think for individuals that's different to understand because in their perspective, that's not the two different silos, that's perspectives of their life. And it's the same with those kind of data lakes and data from different areas of the public sector. We that work within the sector can understand why they are divided into silos, but we have to break down those silos and utilize the big data possibilities that lies out there now with modern technology. So we've had a lot of discussions on that. We have some ideas on what we would like to do, but we haven't started doing it yet.
Well, thank you for the response to that question. And Reggie, who asked the question, thank you for that. That's a helpful thing for us to keep on our radar as well. I think in the interest of time, Anders will move on to the next speaker, but thank you so much for that really thought-provoking presentation. And we'll look forward to the opportunity to perhaps ask another couple of questions of you in the panel session at the end. So stay with us and we'll look forward to that.
Thank you very much.
It's my pleasure now to introduce my friend of many years, Orpah McKenzie. Orpah has dedicated her career to advocating and enhancing the care of First Nations people. She's a graduate of Lakehead University School of Nursing and a member of Muskrat Dam First Nation. As the former Director of Health Services at Keewaytinook Okimakanak, my apologies, Orpah, Keewaytinook Okimakanak, Orpah was involved in the development of telemedicine in First Nations since its earliest stages. She enjoys the development of new ideas and projects in telemedicine and believes that despite the struggles in the early stages of development, that this is an exciting time to be working in this area of health and technology. Orpah, it's really terrific to have you join us today, and we're really looking forward to hearing your perspective on digital health. Welcome.
Thank you. It's good to see you, Sarah, and everyone else here. I'm sorry I was late this morning. I had my time wrong, but anyway, I will do the best I can here to tell you a little bit about KO eHealth's journey. The first 20 years. So we were kind of dabbling in telemedicine even before that, but officially I think we counted as from about 20 years ago. So I'd like to acknowledge that KO eHealth and health offices are located on the traditional territories of the Grand Council Treaty 3. And we have been located here since 1998, I believe. And it's been, we work with them as well too in developing telemedicine. We have some communities that have the mini telemedicine, and we're looking at trying to get the room-based video conferencing unit into one of their communities now. So anyway, my objective here to discuss the best relevant practices in telehealth virtual care in a broader conversation about eHealth delivery experiences. So we have been through this for a number of years, and we've come up with some things that we said, okay, well, I guess we'll learn from this one and move on, try and develop our project. And that's what it's been called for most part. It's been a project. It's not a program yet of Indigenous services at this time. So some learning objectives, participants will know how eHealth figures in Ontario's Ontario's system of virtual care, understand the limitations of a transportation-based medical model for delivering care in remote Northern First Nations, are aware of the risks and opportunities of using virtual tools and platforms to deliver care with Indigenous communities. So we start with the next page, the KO first event. So as I was saying, like we were starting this this telemedicine. We started off even before this event in that we tried out telepsychiatry in Poplar Hill in, I believe it was in 1998. And so that was our very, very basic, that was even before fiber. That's what we were doing, trying to provide access to psychiatry services because we didn't have mental health services available in our communities, except for a few communities that the regional service provided. So for the first event, this was in March 2002. So there was a family who had a young son that was in Toronto at Sick Kids recovering from open heart surgery. And so they wanted to see him. They couldn't travel. Certain times of the year, it's just not great to travel anywhere. Most of our communities that we serve are fly-in communities. So there was no telemedicine in Pikanchikam at that time, but it was in Poplar Hill. So Poplar Hill is kind of like a sister community to Pikanchikam. And so it's, I don't know how long it took these aunties to drive over that melting winter road. So around this time of the year, that's when the winter road melts. And this is how they got to Poplar Hill to visit the child for about an hour, I believe it was. So you can see from the photo to the top photo, one of the first, I believe, the telemedicine units that we had in the communities. Quite bulky and heavy, but it lasted. It was quite sturdy, and they lasted. I think at minimum 5 years, and that's the way most of ours are now too. But they're much more slimmer and mobile. So community origins. So we have. As I was saying about the telepsychiatry pilot, we first started experimenting with secure clinical video conferencing. In 2000, eHealth, our KO eHealth partnered with the Legacy North Network, today known as Ontario Health Digital Services, or OTN. So that was when we first got together. There was a pot of funding that was given by Indigenous Services, and we were given some funding to do some community engagement. So we did the First Nations part, we did all the KO communities, and then I believe Dr. Brown did all the other communities, hospitals and clinics, I believe, in Ontario. So we had a meeting with the Indigenous health leaders that kind of created the foundation for a regional delivery model. All the communities had to agree to want to be part of this system, and they signed up and said, okay, yes, this is the way we're going to do it. So we have a common vision. We outline a common vision. We outline roles, what KO's role is, and then we outline the community roles, and then we sign off. And so it was quite the task. Like we say in Northern Ontario, it's huge. I'll show you a map and then a few slides down. But to get everybody to come together and decide together that they wanted to work on this model was a chore for sure. I wasn't part of that specific part of the development, but I was part of the earlier development. So some of the barriers that we deal with every day, it's like the burden of illness. People are very sick. They have chronic diseases earlier in life. We experience more malnutrition, attempted suicide, and we have a significant shorter life. And so that all impacts on the care system, the health system. So access, First Nations who live on Northern Reserves have little to no face-to-face access to clinical specialists. And I think that was that access was the most important thing that we thought about when we were developing telemedicine. It would provide access to services that otherwise wouldn't be available to people. Right now, like as a transportation-based model of care, if something is OHIP billable, then you would be able to get access, like you would be able to get your transportation paid to go and see a specialist. But if it's not, like with things like diabetes care, addictions care, we don't have that. And so most of that kind of care is delivered through telemedicine. So patients flying out hundreds, thousands of kilometers from their community, continuity of care. So sometimes communication between community providers and specialists is uneven. So we have to deal with that as well too, and try to ensure that the communication continues on once the patient comes home. So that's something that's now we have e-logs that we have when a patient sees a specialist on telemedicine, that there's a record of the visit, and at least people know that this patient has seen a specialist, whereas before they might go and then they might not be able to, the information from there may not follow. I know we've thought about trying to develop a patient EMR, but that's still, I don't know how long away it is. But when we look at infrastructure, I think one of the biggest barriers for us that we deal with every day, electrical infrastructure, most of the communities have are diesel. There is a power grid going up. I believe it's in Pekanchkam and some of the community, it's on its way to some of the other communities going north. But yeah, to run the equipment and that, you need to have reliable infrastructure, electrical infrastructure. Regional telecommunications infrastructure is owned by Canada, so it's almost kind of like out of our hands to be able to do what we need to do to ensure that that we can continue to provide service to the communities. It's kind of a very tough part of it, and of course it's very expensive as well too. And the way it's been set up is that the fiber optic cable is laying on the ground, so it makes it vulnerable to breaks and subject to repair delays, so you can't easily get people in and out to do that. So we've trained local technicians to be able to help out at the community end as much as they can. We have KNET, who does a lot of the other major repairs that involve the KNET portion of the technology. And then of course we have help desk for OTN, and then they look after anything that's OTN related. So a lot of overcrowding. I know that there's a move on to have smaller devices, be able to have care in the home, but for us, it's that we have overcrowding conditions. So that might, that's not going to give much privacy. So most sessions must occur at the nursing station. So the next page, next slide, just shows where all the locations of the sites are. For the room-based video conferencing, it's 26 sites in the Sulakaut area. And then we're fully interoperable with provincial virtual care. So we work together with OTN and Ontario Health as well to try and make things as better as possible. This is something that has gradually come over the years to partner with Ontario Health. A lot of this is primarily funded by Indigenous services. So we manage 26 remote points of care. We have full-time staff person there, community telemedicine coordinator, a local person who we train virtually, and we have a trainer in Bombertown that does all that. We train all the nurses as well too that need to learn how to use all the equipment, and physicians as well. We train physicians when they come on board to serve in the north. So we have these other 39 additional First Nations that we provide what we refer to as mini telemedicine. It's actually what we call the managed service model, and it utilizes OTN's guest link. So it's a portable, like laptop, microphone and camera, and it's done through email. So there's no I guess virtual private network that is required for the room-based systems. So the room-based systems, like we've been asked lately, like, will Starlink help our systems? Can we have emergency services in our community? But Starlink won't do that. It only looks after internet-based systems. So because of this, because we manage all this in what we call these sites as First Nation owned and operated, excuse me, we can look for services that are a priority for First Nations. And most of the time it's mental health, addictions, and diabetes care. And we still do have one of the other things that we make sure that that is available is care for nephrology services, and that because there's a high incidence of kidney failure in our communities as well too. So the next page just shows some service volumes just from 2011 to 12 to 2020 to 21. So it's kind of gone up really high. Like during the pandemic, we almost it grew by nearly 60% over the 2019-20 volumes. It was it was a very busy time for us, and people needed to get on board. It's not easy to just take on a laptop. You have to learn how to do the system, sign in and out, because it's a secure system. So over the years, we've provided more than 30,000 unique clinical appointments for Indigenous clients living in remote flying First Nations during the last 10 years. That's a lot of clients. And I'd like to say sometimes that in Sulcout, it seems like there's 2 hostels there already, and they're always full, and they're always looking for hotels to try and provide services to clients. And that, so I like to say that telemedicine alleviates some of the crowding and the travel. Like, it's not easy to travel, it's very expensive. We used to be able to keep track of how much money was being saved, and I believe I can't remember which year. It's been a couple of years now that we haven't had to keep track, but we were up over $5 million a year. We were saving there. Some of the lower ones there were like about $1 million. We never went, oops, there's my clock. We never went below, much more below than $900,000 in 1 year. And that was a bad year. It was like when there was like forest fires all over the north. So Northern Service Modeling. So this is requiring a long-standing commitment to community engagement. Community engagement isn't a one-time thing. It's ongoing. It's every day. We're continually speaking to communities, ensuring that they keep up with what's going on in telemedicine. Yeah, and it's something that we're kind of short of. Sometimes we're short of staff to do all that work, because it's quite intense. And then especially when there's any new projects, we need to ensure that communities are well informed about and that they're able to have some input into any new projects that are happening as well too. So listening to community members and providers creates a foundation for growing new health resources. So we've grown quite a bit since we started. Never thought when we first started there that we would get to this far in this project. So hub staff, that's at the office in Bombertown. We have people that provide training. They manage this new service development, and they also support the technology. Community staff manage patient admin workflow. They ensure that patients are aware of their appointments. They receive and confirm appointments for patients. They fill in the e-logs, they schedule, they send reports to the schedulers, and ensuring that nurses are on hand in case the physician requires a nurse to be on hand for the consult. So some service model key capacities. So anyway, we have like I was talking about some of the priorities. So for this chart, it just says that we're in Ontario, the first reason for use of virtual care is mental health and addiction. Second reason is diabetes. Third reason is speech language. Now, speech language has been rising now because I think it had to do with, with when Jordan's principles started coming on into the communities, that they started identifying this as an issue as well too. It's been there before, but but nobody was there to really work with the children. We didn't have people available. So now we do. And so now that's the third reason why we use telemedicine. We also have a link to Manitoba, especially Winnipeg. So their first reason is genetics, and then gastro, and then nephrology is the third reason. So our connection with Manitoba is because of the referral patterns. Back when I was first starting to work in health, the major referral pattern was to Winnipeg because it was the closest to the communities, and that was Health Canada policy. You refer to the nearest point of care, right? But now, we can see people in Ontario as well too. Excuse me. We have access to physicians in Ontario now too. So 92.5% of all services by KO were delivered by an Ontario provider. So that has changed over the years. And of course, we're always trying to deliver services as close to home as possible. And also the other thing is to increase the available pool of clinicians who practice virtual care. At the beginning, it was a little bit tougher, but now, like, especially with COVID, we've had a lot of requests to be able to use telemedicine, laptop telemedicine as well. Northern service models, the next page, pictures of some of our staff and nurses in the nursing stations. And there's a picture of I think it's a telemedicine coordinator on the right, on the bottom. We have the telemedicine coordinators that are full-time. We encourage the community to hire somebody that's a backup, so that when a coordinator is not available, then I have somebody that can do that. But more and more over the last few years, I would say the last 3 years, we've had Health Canada's been interested in having nurses trained to look after the telemedicine unit as well too, when needed. So that's really helpful. The next page is about the telebabies. We have prenatal confinement. It's almost, I forget how long it is. I think it's about 3 or 4 weeks that the ladies need to come into to Sulako to wait for the baby, but some people don't want to leave. Some women do not want to leave their community to have their baby. But it happens sometimes the babies do come earlier. And so we've had about 16 babies delivered, kind of like we weren't expecting kind of thing. But there are now clinical staff that I believe it's in one of the larger communities, that they have a room where if they need to, they actually have a room, and they actually have staff in Sulako that will have that will help with the delivery if need be. So it's an urgent service, links nursing stations with the Minoyawa and obstetrics team. So this is new. That's really new. I think it came just after we did our telemedicine. One of the other things that we has been very popular is the elders gatherings. And that one is a monthly gathering where elders from all the sites, the room-based video conference sites, they get together and they have a message. We usually get a nurse, or maybe it's somebody from Asthma Foundation, maybe somebody who can talk about elder safety, that kind of thing. So it's for that purpose, but they also get to share a meal, a healthy meal. Usually we try and keep it very healthy. And so it also has a social cultural purpose too, where the elders can visit other elders from different communities, and they just have a great time. They talk to each other and tell jokes and whatever elders also do. We used to have a big Christmas one, but we haven't been able to now with COVID. So now we have teleophthalmology, and I think I've run out of time here. Teleophthalmology started in Sandy Lake in 2002. So because of the incidence of diabetes, there's always that risk of retinopathy. So a nurse travels to the community with a camera and screens elders, anybody with diabetes to check for retinopathy. So we work with a regional ophthalmologist, and the screening visits are usually 1 to 2 years as soon as we can, as at the community's request usually. So a picture of the old technology, the new technology. We're looking at another new technology again too, but nothing certain yet funding wise. Virtual emergency services, that would be my last slide. So we started this in 2016 with Indigenous Services, Orange, OTN, nursing, and 4 First Nations to provide emergency services. So you see on that picture, I believe that's one of the units, the mobile units in one of the nursing stations, and they just provide they get to connect to Thunder Bay Regional's RCCR, Orange Transport Medicine Specialists also connect with us as well to ensure that the client is stabilized before travel. And so in 2021, Orange and RCCR teams attended 196 urgent emergent video-enabled events for 125 community members. So it was one of those services that we requested in our initial community engagement, but of course that has a lot of parts to it, right? Moving parts. So we didn't do this until much later, until we had the basic stuff down pat. So that was good. Now it's in 17 First Nations. We're looking at possibly doing another 5 next year, expanding to all the Sulcode area communities. So that's my presentation. I know I probably went a little bit longer. I'm sorry, I apologize.
That was just terrific, Orpah. Thank you for that. It's really helpful, I think, to hear your experience with KO and to have followed Anders, who I think set the stage about, the big data picture and some of the vision pieces. And I think you've really touched on a couple of really important pieces around implementation of a strategy for healthcare service delivery, including skills and resources. And you talked about fiber optic cable and internet services and skilled providers and skilled staff. And I think highlighting those elements as part of really key features of how we implement digital services and healthcare delivery services is really, really helpful. And I really hear as well the way that you've embraced the opportunity to use the KO network for everything from consulting services to education of elders to now emergency services delivery and telebabies. You're using the tools that you have to really optimize the amount of care that you can deliver. And I think that is really terrific to hear. I'm going to go, we have one question, Orpah, and we'll likely also ask this question of our next speaker as well. But the question is whether or not you have portable options for in-house visits by community paramedics. And I know not all of the KO communities have paramedics, many don't. But for those that do, is there an option for using tools like an electronic stethoscope or other diagnostic tools with a tablet in the hands of paramedics in the communities?
We don't have any in our area at this time. We don't have paramedics, although I think it's come up as something that we should look at. But we do have, like, as part of the room-based video conferencing system, there's an ENT scope, and then there's also the telesteth, and it's a complete stethoscope, electronic stethoscope. So the nurse can use that. Even the CTC is trained to use that. Because sometimes even when there's an emergency, it's like, use all hands, right? You try and make use of everybody, train everybody to know what they can do, how they can help in that kind of situation.
Well, thanks very much, Orpah, for that, the response to that question. One of the things that I have as a question, as well as in the conversation about how we're using virtual care delivery tools in the KO territory, and you highlighted the majority of the visits and sort of where those, what baskets of service are being delivered. And I didn't see primary care services in that. And I wonder if you can speak to the extent to which the KO network is being used for accessing specialist care versus family physicians, nurse practitioners who may not be resident in the community, but may be able to provide some service to the communities.
Yes, our numbers, I don't have them handy right now, but our numbers have increased dramatically with primary care over this COVID period. And before that, it was here and there, and I think a lot of it was related to when the weather's out and the doctor can't get into the community, then they use it, right? And so, but the specialist care, I think that was the main thing that's always been what we do. It's like our bread and butter kind of thing, and elected, like, what do you call that? Services that are like follow-up services, initial services. I know that Minuyawan, I remember when I first came back to KO, Minuyawan, they were just learning how to, trying to work out a system. That's where I really enjoyed what Andrew said as well too, is it's a system, you know, working out, okay, what's our present system? How do we do this? How many times does the patient have to come out here to get surgery done and go back and then come back and do follow-up appointments? So they looked at that whole continuum, whatever it is you want to call it, and said, okay, at this point and at this point, maybe it might be the best appropriate to have telemedicine, use telemedicine. So they integrated into their service, right? And so I think that's the way it needs to be. A lot of times, like, and we've mentioned this to providers, sometimes too, like our First Nation providers, and that where they're struggling with people maybe not showing up or anything, you know, maybe, you know, work it out so that there is time when it's appropriate for a client to come out and, you know, see a caregiver face to face, then it's probably best to use it then. But yeah, it's the primary care. We were very surprised, like during COVID. Well, I shouldn't have been surprised. We said maybe anticipated it, you know. But as it turned out, yeah, a lot of physicians started using telemedicine then. Yeah. But not with the changes, I guess, with Ontario and their remuneration kind of thing. It'll go back, you know.
Right.
So well, a lot of outside things that kind of impact the use of telemedicine. Yeah.
Well, thanks so much for that response, Orpah, and we'll really look forward to being able to ask additional questions in the panel before we close for today. So thank you for that. And we're going to go next to our next speaker, Venky Kulkarni, who's the Chief Technology Officer and Managing Director of Digital Direct at Medavie. He is a seasoned transformation and technology strategist. He's led complex business and tech initiatives for a variety of global organizations, from Fortune 500 companies to emerging startups. He provides strategic leadership and oversight to drive Medavie's business transformation. He has over 20 years of progressive leadership experience, including Director of Technology for WellPoint, one of the world's largest for-profit managed healthcare companies, Director of Tech for GE, NBC Universal, and very interestingly, as a consultant with the Walt Disney Company. We may have to have a future conversation about that, Venky. In his current corporate role, he serves on multiple boards and enjoys nurturing early stage startup companies. And we're really looking forward to hearing from you, Venky, today about your experience with Medavie. So welcome.
Dr. Newbery, thanks for that very kind words. And I'm really excited to be here. And hello, everyone. In today's discussion, I'm going to focus a lot on our background on Medavie. But first up, I just want to make sure that I acknowledge that where I'm calling from. I'm calling in from Moncton, New Brunswick. And this is the land that I'm joining in from, is the traditional unceded territory of the Ulster-Keewaytinook and Mi'kmaq people. And thanks to both Orpah and Anders for their valuable insights and perspectives thus far. And I'm looking forward to engaging in a Q&A. And I will probably not take the entire 20 minutes that's allocated to me. We'll leave some time for Q&A. I'm going to share my slide deck here in a second. It should be coming up. Somebody confirm that I'm sharing my screen.
It's not up yet, Venky. No. There we go.
Better.
Yeah, that's great.
Okay. Well, first, some introduction about Medavie. Medavie is a non-for-profit health solution partner that oversees Medavie Blue Cross and Medavie Health Services. We are the largest Blue Cross plan in Canada. And through the Medavie Blue Cross entity, we provide health, dental, travel, life, and disability benefits. And 1 out of 12 Canadians are covered by our plans. We also administer programs for the Veterans Affairs of Canada, as well as we are running the administrative program for the Nova Scotia Medicare. On the health services side, we are a national health solutions company, and we are the largest contracted ambulance services, medical communication, clinical training, and mobile integrated health programs, including community paramedicine, which has come up a couple of times already today. We have roughly 7,200 professionals working coast to coast to coast. And our mission is simple: to improve the well-being of Canadians. And we are a national company. On the Blue Cross side, we have almost 3 million people that are covered by our policies. And we serve more than around 2.5 million people on an ongoing basis. Our contracts on the Blue Cross side is about 1 million people that we serve as on the private insurance side. And this is the key to our company here. We are a value-driven organization, and our core values are caring, accountability, responsiveness. And 2 of the values that are so key to today's discussion is around innovation and community-minded. And when we talk about Medavie, we go back to these pillars. We go back to our values when we make decisions and how we operate on a day-in and day-out basis. The next one is really, and I want to just set the stage of how we think about innovation within the scope of Medavie. And you'll see 2 recurring themes here. One is around the human-centered, and the other one is about community. So within the innovation philosophy, also we are taking a really personalized healthcare experience in order to deliver that is supported by humans. It's empathy is at the middle of what we do, and to support accessibility and health outcomes. So that's really our focus: is how do we deliver digital solutions that are supported by humans? And we always have seen technology and digital technologies as an enabler to existing processes, existing procedures, and not as a substitute necessarily. It's not a sector by itself, it's an enablement of what is happening.
Venky, just before you go on, I apologize for interrupting. Your slides are so valuable, but they're showing up a little bit small. There we go. That is perfect. Thank you so much.
Sure. Thanks, Newbery.
I apologize for interrupting.
That's fine. So the innovation philosophy, we talked about it, how we are approaching from a human-centered design. And this one really sets the stage of our operating principles. In the center of it is really what we monitor, how we monitor. And that's really around 811 health, telehealth, we'll talk about it, virtual health, case management on our Blue Cross side, remote patient monitoring, and communication and triage coordination. That's really where and how we monitor. And our points of contact are at different places. And we are an outcome-driven organization. We are outcome-driven. We have outcome-driven programs across. And it's a whole person approach to healthcare services and delivery, and while engaging patients and practitioners. There is no doubt there is a growing demand of healthcare in Canada, and just like Andres talked about elsewhere too. How do we manage the demand and supply of it? What are the newer ways that we can manage the demand, and how do we manage the accessibility and the affordability of individuals that are looking for healthcare, whether it be on lifestyle, wellness, or some chronic disease that they're trying to manage. That is really our person-centered approach, leveraging digital technologies and how we deliver them. And I'll get into a little bit of how we deliver. Now, a little bit of our presence in Northern Ontario. Now, through the Indigenous Services Canada, we provide paramedic services to support the Northern Indigenous communities. We have about 200 rotations that have been completed to date in the Northern Ontario region, and work is still going on. We work alongside with several of perhaps people in the audience here, in the healthcare professionals in these communities, including First Nations, and ensuring that nursing stations, health centers can continue to provide life-saving care to their communities. And as we step into the digital health ecosystem itself, I want to talk a little bit about the evolution of healthcare and the trends that are fueling the digital healthcare here. Just like any other industry, the trends that fuel digital healthcare is coming from the same drivers. It's the rapid adoption and the rapid change in technology, consumerism, and personalization. And technology is enabling the demand, enabling the access to healthcare from anywhere and anyhow you want to actually do it. A simple app that's accessible on mobile device to make an appointment is a good case in point. Or you want to connect with mental health practitioners, or you want to connect with a nutritionist. Those are all enabled by existing technologies. Consumerism is really, from the way we define, is like people are ready to take control of some of their perhaps diagnosis, or perhaps some of the information they are seeking to, and the people are looking for solutions that after they do some research, or perhaps they come with a solution towards a practitioner, and that's really consumerism. How do we now fulfill that demand that's actually growing out of consumerism? And this probably started about 20 years ago, and we are really seeing the tipping point of consumerism that's happening now. And personalization is a key to aspect. We understand everybody is different. People have different situations. So it's one size does not fit all. We understand that too. What solution might be a good one in the urban areas may not be a good one in rural areas and remote areas. So we have to think about not only as a segment of one, but personalization in the segments of where we are in geography, in the gender, and in the cultures. So we really look at some data aspect before we start to draw solutions about where we operate in. And the e-patient, now this is one of my favorite slide and topic to talk about. What has happened here is, by and large, a lot of people are equipped. We're equipped with devices. We're equipped with internet. We're equipped with information. Now, I do also want to acknowledge there are a lot of areas we don't have that infrastructure that Orpah, you touched on a little bit. Besides, some of that, we are seeing a lot of members and consumers that are equipped with this kind of either devices or information that are coming to as an insurance or a healthcare delivery partner. A lot of folks are engaged. A lot of people are engaged in taking care of themselves, and they are enabled. And the enablement here comes from they have the ability and the power to participate in their own health and want to take control of some of the situation. And we have an empowered consumerism that's growing, where there's information that's being pushed on different media, different channels, and that empowerment comes from information there's an information overload too. But as long as you're able to filter that information, there's empowerment of the consumers that's happening. So the evolution of healthcare itself in the past used to be, of course, it was a physical visit. Doctors and first responders either visited to the patient or vice versa, depending on the situation. And that has slowly evolved over the last couple of decades. And a combination of in-person and digital health And we do that day in and day out. We have, and I'll talk a little bit about our partnerships where we are working on, whether it be delivering mental health kind of capabilities, treatment for mental health capabilities, disability management, or delivering medications. We'll talk a little bit about some of the partnerships that we have created in order to support the evolution of digital health. So here are some examples that I would like to touch upon. So digital health, of course, benefits are there to people in terms of accessibility and affordability. Sometimes, perhaps there is early diagnosis of a situation that can help manage chronic diseases outside of traditional healthcare setup. There are benefits to healthcare providers, which provides a holistic view of patient health and supports the continuum of care. Some of the examples that we can talk about is EMR records. It has come up earlier in the discussion today. Wearable technologies such as, we might have something that tracks how much you walk, how much you sleep, and the nutrition that you probably are consuming. Data analytics, which has come up earlier, it is so incredibly important to the success of digital health delivery and personalization. And there are technologies that has developed around, cloud computing that makes it much more easier now. But also it's more complex than it used to be because the number of data points have dramatically increased. Remote patient monitoring is a key element. I think there was a question earlier about some of the paramedics visiting with ability to connect the LTE tablets. And there are capabilities out there on remote patient monitoring, and we are participating in that. Health and wellness apps. I think Andres, you talked about the number of millions of apps out there. And we are one of them. We have a credentialized app that's out there that I'll talk a little bit about. Secure video messaging is another channel where people are communicating with healthcare providers on video chats, on phones, where it's available. The on-demand access, this is really driven by the growth in consumerism, by the growth in personalization. The way we look at is, and our commitment is to providing our plan members and patients access to virtual tools, access to information that we think is going to be helpful for them to successfully navigate and manage their overall healthcare. So what are we doing in terms of the virtual and also ability for our members and patients to consume digitally? Number one, we have a diabetes care. We have a platform that's called a connected care. The first one is around diabetes care. We really provide plan members with exclusive access to AccuCheck and 360 care. There is a digital coach that's available to take you through your journey. We have a partnership to provide online doctors where you are able to get onto your tablet or your phone or your computer and connect with a doctor for smaller things. And it's not about chronic disease management, but it's about, my daughter had an eye problem the other day, and she actually dialed into the portal to see what was the cause of that. We provide personalized medicine, pharmacogenetics testing, and preferred pricing to our members through our partnership. We have a partnership with Virtual Physio, where you are able to connect with a physio remotely and check in with, if you had a bad elbow or a neck pain, but you cannot actually drive to somewhere. So we are connected with our connected care to a virtual physiotherapist. And quite recently, we have partnered with another startup that actually allows our members, the Blue Cross members, to have timely solution that enables to build mental health support system. And that's coming in form of connecting with our existing digital technologies to a partner technology. So outside of the connected care, we also cover many virtual services through traditional extended health benefits. And I'll talk a little bit about that in the future slides. Village Hub is one of our newer offerings. And what this is really is changing the way we make appointments. We understand that appointments is a significant friction point when you're trying to get in front of a dietitian or a physiotherapist, like I just talked about. So what this does is really to look for a provider in your area that's available at the time that you have been used to or you want to, and actually make your appointments seamless. We just released our initial version of this in the market, and we are working actually in Ontario region to welcome providers that would like to try this for our members. 811 telehealth systems. 811 is really the ability for people to call in from a provincial healthcare standpoint that offers 24-hour, 7 days a week telecare services over the phone. And we are, as you can see, we are in several regions in Nova Scotia. We have been doing it for many years. And with COVID-19, we had pandemic response system that actually came out of the 811 system. We are the first non-public sector telehealth services in Canada that has been accredited by Accreditation Canada. So as you can see, our digital health solutions are also supplemented with other ways that we are actually connecting with the community. And this is the other portion of the community that I talked about earlier. This is our ecosystem, and a lot of them are in our connected care. And these are some of the partners. I talked about the capabilities earlier, so not get into a whole lot of details around it. We can deal with in the Q&A if there's any questions. And I just want to touch upon a look into the future here. Now, COVID was a digital shock. It really accelerated a lot of things that were in the works probably for the last 20 years. I remember when Y2K happened, the internet was a big deal, and we thought the solutions are going to be back in 2000. It took the pandemic to actually accelerate a lot of those things. There is a lot of things on the horizon that actually this last 2 years has taught us. The foundational aspects of data analytics and empathy for people, I think they have been reinforced over the last couple of years. And there are really exciting technologies that we can look to solve some of the traditional barriers that we had, like reaching people or having a continuous set of data that actually helps people to monitor and provide the provider with enough information on an ongoing basis to have effective treatment, which all will help in outcomes and actually having loyalty and patient engagement and patient experience, which is going to be the key for our success in how do we actually deliver care that is accessible, affordable, and also delivers the patient experience that everybody is seeking to actually get out of the system. And I'm going to take a pause there and hand it back to Dr. Newbery for you.
Great. Thanks so much, Venky. That was a terrific presentation. I have a question from Joel about how, and this perhaps builds, whoops, I don't see my video on, sorry. I think I just need the host to open my video and then I can join. There we go. Let's see. I think that's better. Great. Venky, thank you so much for that presentation. I think that was really terrific. I have a question from Joel, which is perhaps builds a little bit on Anders' earlier presentation about using data and understanding data to inform decision-making. And his question is about what tools are needed to address, how Medavie determines what technology tools are needed to address some of the health system challenges, what data might underpin that, or what information underpins Medavie's decision-making.
Yeah, where we start is the number one is we start with our mission. When we are trying to make a decision on whether it be tools or offering a solution, does it align with our mission of improving the well-being of Canadians? And then we look at our value system. Does it fit into the value system? Is it community-minded? Are we doing something about it? Are we responsive? It fits with our mission and the values that we are delivering. Then the solution is really about who are we solving the problem for? And that's where the empathy piece comes in. Who is the solution for, and how do we go about doing it? And then you can layer on tools on top of it. If you're trying to answer a question of who is the solution for, and are we trying to solve the right problem? There are different tools. We introduced something of a design thinking nowadays, a human-centered design competency that we are building in-house. So we layer in on top of it to say, are we now solving the right problem for the right set of people? Then I think coming back to the question itself, what tools do we use? Then it is like, is it secure? Is it compliant? we need to cross those barriers. And then the third question then becomes, then the field gets narrower when you start to think along those lines. What solutions offer us the best optimal solution that we offer value to our clients? And then you start to layer on different elements. Who will be the willing partner? Who can we go to bat with? So those are kind of the decision making that goes into this process. Yes, it becomes a little bit of a complex decision making. We need to do all that to ensure that we have the right framework, the right security, and the solution that we provide to our partners. And at the end of the day, then the data analysis and the data aspect here comes down to we have adopted cloud computing. So we actually look for cloud computing solutions that a partner has got experience with, that we can trust whatever we provide the data or information, and then make the decision.
Thanks so much, Venky. So what I'm hearing is sort of concentric circles of decision making, but starting with the patient and the patient need at the center.
It is absolutely at the patients at the center.
Great. Thank you so much for that. We have another question, which I think you have spoken to briefly in your presentation, but there's a request to elaborate on the types of advancement that you're seeing in digital healthcare and digital healthcare delivery.
Yeah, that's a great question. I think at the base of it, we take a step back from what has happened in the last 20 years or so. Healthcare systems en masse have gone through a tremendous transformation. I think some of us lived through this. EMR systems, patients, one patient, one record, followed by patient portal, provider portals. We've seen this happen over the last 20 years. And what is coming is the patient experience. That's where I see things going, is that how do we deliver the experience that the patient is looking for and is used to in other places that you probably don't get the same from an end-to-end basis in healthcare system. And that translates into some things. That means, how do you have, a personalized healthcare? How do you make it easy? How do you remove barriers for getting to the right care at the right time? How do you help the person navigate to that place? So those are the questions that needs to be answered over the next several years. And then the technologies that I'm really get excited to solve for those problems are things like artificial intelligence, and it's here to stay. There's a lot of regulation, a lot of governance, a lot of lanes that need to be built to ensure that AI is actually doing the right thing for the patient and the provider. Mm-hmm. So I get really excited about what AI can do when used right in the right way. And if I was a practitioner, a physician or a clinician, I would be excited about what 3D printing can do. What DEC solutions can do. It's a prosthetic leg, and we can actually spin off things more quickly than we've done in the past. I would be excited about that. A third one is about augmented reality, and actually how that AR can actually get into the space of helping patients get the right care. And I'll talk about the fourth one, and then I'll stop there. Drones are going to be an important technology here of delivering care to remote places in rural areas where traditionally it has been hard, and even for caregivers to get to a certain place, it's hard. And I get excited. I saw something recently of a drone delivering blood as an experiment, and the future of that is real, and it's there right in front of us. So I get excited with all these things what it can do to solve our current problems.
Thanks so much for that. I think we have time for maybe one more question before we go to the panel portion of our workshop this morning. And the question is how organizations can make the digital health experience seamless for individuals. And the corollary question is, how do you personalize that experience?
I think the first one is, number one, we need to have, we as leaders across the board here understand that this industry has gone through the transformation I just talked about. And there is a lot of things that have happened in the last couple of decades. And what we have the opportunity is to have better collaboration across different sectors. across the board, public, private, within private, different sectors. I think there's a humongous need to drive enhanced collaboration in order to make the digital health experience seamless for the patient. And it goes without saying, get the patient, well, they get the individual in the middle and then design the solutions around the individual, which means you require that collaborative unit to say, how do you navigate, for a person that has got some disease, how does that person navigate first? So, currently, nowadays people use the word digital front door. So what's that front door that can be opened, and then you have to get navigation, so they request collaboration across units. And then the infrastructure underneath needs to talk to each other. Andres talked about a little bit about how they're doing in Nordic, something of that extent. How do you make that seamless transition from one place to the other, let alone within provinces, but across the provinces, across the country? I think that's going to be really critical for organization to think about how we want to operate in the future. Now, each one of us are investing significant amount of dollars in our own way to solve our own problems. I think that needs to have a collectivity to that solution. And then how do we personalize the experience is really being careful also at the same time, but also use the data that we are all sharing to know more about me. And that goes back to the empathy comment. It's like, a solution for me may not be the solution for you. And how does my data actually get in the hands of a doctor or a provider that knows more about me, that I can personalize the solution? So that experience of collecting the data, knowing more about the patient, having the empathy, and then having different solutions, that's what we do. We are always looking for that data points to see, is this the right solution for the person? Are we actually solving for Venky, or are we solving for us, right? I think that empathy needs to be in the middle. Empathy and collaboration will be the two key elements that I see as opportunity.
Thanks so much, Venky. As you're speaking to that, I'm thinking about Anders' almost infinity diagram with individual system and data in the middle, and how do we build the systems that support the individuals and connect the data in the middle. So thank you for coming back to that, or touching on that kind of concept. I'm going to suggest now, with our thanks to you, Venky, for being our third presenter this morning, that we move into the panel portion with a few questions before we need to close in about 15 minutes or so. So I'll look for Anders and Orpah to join us in the panel. And I have a couple of questions to begin with. The first, and maybe Anders, I'll look to you. I don't know the extent to which your remote communities are impacted by internet access, but the question is how internet access to our remote communities affects operability in the system. And I wonder if you could speak to that from your perspective in the Nordic countries.
I can, and I have to say that it was really interesting to hear the presentation of Orpah McKenzie and the examples of the challenges that you face in your parts of the world with rural areas. We also have that in the Nordics, but what the Nordics have is a very well developed system for internet connection, and we have the Nokia, we have the Telia, we have the huge international players when it comes to tele and internet connections. So we don't have that as a big challenge as I would guess that you have. So for that perspective, we kind of see that most individuals in the Nordic countries will have access to internet services. So the challenge for us is not for them to have access, but to help them utilize it in a good way.
Thank you so much for that, Anders. Orpah, I wonder if you want to comment about the operability and the remote communities of Northern Ontario.
Oh, maybe that was for me.
Okay, that's for me. Sorry. That's a big question because we're remote and that, so we have. When we started out, I don't think it was like, I don't think there was anything there. Like, I mean, we were busy trying to develop our phone system in some of the communities at that time as well too. So it's been a big problem to try and maintain that, and because it's it's owned, I guess Bell owns the whole network kind of thing. It's very hard to be able to purchase enough bandwidth to support all the needs in the community, like with COVID. Before COVID, I would say, okay, the main need for bandwidth was for the telemedicine stations, and we have what we call the quality bandwidth. Like we have technicians in Sulakot who will monitor the bandwidth in the community as the consult is going on, so we ensure that the consult receives enough bandwidth to proceed. But once COVID came and students had to learn at home, they were issued these Chromebooks and all that bandwidth, of course, was all, like there was no control on them either as well too. So that really was very difficult for students to be able to continue in that. But at least for telemedicine, we were still able to provide the required bandwidth for the communities. But it's very tenuous, I guess you would say, a lot of times, mainly because like I say, there's only the one provider, and it's an aging infrastructure as well too, so that really makes it hard to connect in that. But for the most part, like for us, we try and keep the system as what do you call it, so that whatever system goes in there is going to work with the other system. We try and keep careful control in that. There are times when there are people like vendors, like technology vendors, who'll go into a community and say, okay, this system is going to do all this for you, but it doesn't work with our system.
Right.
And so it kind of messes up the existing stuff. So we have to try and keep a handle on that.
Thanks so much.
Yeah.
Thank you, Orpah.
I can say about that. Yeah.
Thank you. And Venky, I think you had a comment about this question.
Oh, no, I didn't, but I can add, I think from a remote delivery standpoint, it's really the newer digital technologies such as drones, and I think there's really some potential there, and I'm looking forward to what that can be done, and I think there's some experiments underway in our own country, so that would be a good one to think about.
Thank you. I want to follow up with a question about equity, and I think that this question is one that touches on this part of the language of the presentations to some extent today has touched on consumerism on one hand and the market around healthcare on the other. And we know that often the people who are the sickest and most in need of access to care are people who are the poorest and least able to purchase services or access tools of digital health. And sometimes in Canada, we talk about that as the digital divide. And I wonder, Anders, if you could speak from your perspective initially about how you're maintaining an approach to equity in a market system, which you talked about to some extent, and how you hold equity as a underpinning principle, perhaps, of the work that you're doing.
From the viewpoint we started out with, that the healthcare system in the Nordics was not sustainable because the cost of the healthcare system as it is today is too big. From that perspective, we saw that we had to get the individuals on board. They had to be more involved in their own care. And of course, as soon as you start talking about individuals and the inhabitants being involved, very soon the question about equality is also raised. Because some people will be very well equipped, resourceful, knowledgeable, digital savvy, so that they can start using digital solutions at once, while there will be others that doesn't have the same resources, they don't have the same knowledge. That is an issue that is, of course, very much up for discussion on how to solve that. But at the same time, the scarce resources in the healthcare system makes us also focus that anyone who can be using digital solutions to be part and be a resource in the care process should be able to do so and enabled to do so, so that the warm hands that we still have can be focusing their time on those who doesn't have the digital resources in the same way, so that we can in that sense have an equal healthcare system where those who have the resources and can be using digital solutions will do so, while others are being taken care of in the more old-fashioned way of healthcare for now. And in that way makes it equal, because anyone gets the resources that they need on their level. But it's the digital health is providing us with gigantic solutions and possibilities, but there will be a divide, and that has to be addressed at the same time. And that is also why we in our project is so focused on, it's not just about evaluating and finding the good solutions,
right,
but is in parallel to focus on the activation side. How do we get this into the hands of the right people, those who need it, and how do we train them in such a way that they feel comfortable starting to use new ways of getting care with digital solutions? It's not just to tell them that use this digital app and you will be fine. It's also about building the trust and the comfort of starting to use it, so that they feel comfortable being a part of the digital health system as well. So it's a huge question, and it's a big issue. But at the same time, we need to use everyone on the level that they are. So those who can be utilizing and helping out the healthcare system by utilizing digital systems and find that as a good solution for them, needs to do that for us to have resources for the others.
Thanks so much for that. I think that that's going to be such a profoundly important policy consideration for us to continue to think about in Northern Ontario. So thank you for that. I'm going to go to another question. We may have time for one or two more. The question is whether we're seeing more pressure from governments to use digital as a substitute for in-person care. And do you have a sense of where the balance may end up between in-person and digital care? And perhaps we'll start with you and your perspective from your 5 Nordic country governments, Anders, and then we can go to Orpah.
Well, I think that it's not a substitute, it's a complement. It's to be used to be more, give more flexibility to any individual or care in a care process to be in charge of their own care, but also in better charge of their own life by having this flexibility of utilizing the digital solutions for being in contact with the healthcare professionals or share data or get needed data. But it's not a substitute for the physical meeting and the physical dialogue as well. So again, it's a way of ease the burden on the very stressed healthcare system, but not for people not to get what they need, but to be able to utilize the digital where it is good to utilize it. Thank you.
So thinking about digital services as an enabler of care, when it's the right care, then that's terrific, is what I'm hearing you say.
Exactly. Yes.
Orpah, I wonder if you want to comment on the pressures that you might be experiencing in your communities around that balance between on the ground health human resources and the pressure perhaps to deliver more virtually outside of the pandemic with the pressure that we've all experienced.
Yeah, I think when I think about that question, it's more of, I know when we first started out, there was this whole concern about treaty rights to healthcare, right? And they're saying, is the government going to start telling us that you have to use telemedicine instead of going to see a physician face-to-face kind of thing. And I think the main purpose of this initiative was really, we have to stress the fact that it was just to access care, because just care just wasn't happening. There just wasn't enough care to be provided for the communities, for the amount of, like I talked about, the burden of illness and that. And so we just stress that part of it. And I think a lot of people have been very open to it. And then the other thing that we always stress too, it's meant to be an enhancement to the services that are provided already. Like it's not meant to replace anything. There are just some services like allied health professionals that there's a shortage of them. They can't, there's not enough there to travel to the communities to provide the care that's needed, like physiotherapists and that, or diabetes educators, nutritionists, that kind of thing, or addiction specialists and that. And this is the next best way to having some care. It's better than no care at all. And so that's the way we've always promoted it. And I think that sits well with a lot of people. They like the convenience. They like not having to travel. You know, for some of them, it's a big excursion to have to travel, especially with elders or those with young children. So, and I think, as far as I know, Indigenous Services has been, I've not known them ever to kind of put any kind of pressure on anybody. And as far as working with Ontario Health and that, I haven't seen that yet either. Yet, I shouldn't say yet. I won't do that. For sure.
Thanks so much for that, Orpah.
Yeah.
Part of what I'm hearing from both of you, and there was a question that we don't fully have time for. We'll invite Charles to come back for closing comments. But I think you've both touched on the importance of relationships, not just with individual patients or citizens, but also with communities as we introduce new technology, as we introduce new care delivery options, that the uptake of those services is going to depend on the degree to which we've built trust with individual patients and with communities and with healthcare providers as well. And so I really appreciate in both of your talks the way in which you positioned the importance of trust and relationship, even as we move increasingly into a digital care delivery system. So thank you for that. And with that, I will turn it back to Charles for closing comments. Thank you both so much.
Well, thank you, Sarah, for doing such a great job moderating that, and to Anders and Orpah for being willing to take the time away from some amazing work to talk to us about it and suggest some of those solutions going forward. My job is to close off the day and let you move on to the rest of your afternoon. So thank you again for all of you for attending this eHealth seminar. I want to again thank our speakers, Orpah McKenzie, Anders, and Venky. Venky unfortunately had to leave earlier for an appointment, but I hope we learned a lot about what Medavie is up to and some of the interesting thoughts around drones and AI. It's going to be a fascinating future in healthcare, as it always is. I want to thank our sponsor, Medavie. And again, I want to thank Dr. Newbery for doing such a wonderful job moderating today. I was receiving notes from my team on the back end saying, so how can we convince her to moderate all events from NPI? So I'm not sure that's a banner, but we'll see where we can go. In terms of this event, I want to make a highlight that this is the first event in a series of webinars that Northern Policy Institute and North Superior Workforce Planning Board will be running. We believe that addressing the vulnerability and unique needs of remote and rural communities are of the utmost importance, and our digital webinar series aims to put consumers in touch with service providers and policymakers to speed up the development of a fully functional, safe, and secure digital society. We can break down the chronic isolation of remote communities and work together to improve access to essential services and relationship building opportunities. We will be taking the talks from today and the Q&A as a way to inform upcoming themes for future webinars. And I'm happy to say that our next webinar is planned right now for March of 2022. And the theme is going to be virtual communities of practice in remote and rural communities. And we hope to see you all again at that event. And in the meantime, thank you again for attending. Have a great day.